You can go in.
Okay, great. Thanks. Got the bat signal. So welcome everyone to our webinar, A Pathway to Transforming Patient Care Through a Pain and Opioid Learning Health System Learning Collaborative. We call it POLLC, P-O-L-L-C. I'm Ann Merka, one of your hosts today, and I'm a pharmacist and Senior Director of Drug Safety and Chronic Disease Management at IPRO. And thank you so much everyone for joining us. We are thrilled to provide you the opportunity to hear from our distinguished panel of POLLC participants. And our hope is that you'll find inspiration on ways that you can apply learning health system concepts in your own organization and communities. Next slide, please. So here you'll see the IPRO Quality Innovation Network and Quality Improvement Organization map. IPRO QIN-QIO is federally funded as a Medicare Quality Improvement, QIN-QIO is how we say it, via a contract with the Centers for Medicare and Medicaid Services. There are 12 regional CMS QIN-QIOs nationally. We have partnered with Health-Centric Advisors in Clarence to bring this work to 11 states and DC. And overall, our region accounts for 20% of the nation's Medicare fee-for-service beneficiaries that we provide, that we work to ensure high quality and safe health care through quality improvement. Next slide, please. And I'm joined today by my co-moderators, Dr. Jerry Osheroff and Lynn Wilson. Jerry, do you want to introduce yourself?
Everybody, I'm a primary care internist by training and led a lot of the initiatives that I'll be talking about shortly that fed into POLLC. Very thrilled to be working with IPRO, all the fantastic participants in POLLC, and very grateful to have you all here today to share with us, what we've done and hopefully have it benefit things that you're trying to make happen.
My name is Lynn Wilson, and I am a Senior Quality Improvement Specialist with IPRO, and I have a lot of years experience with quality improvement in both regulatory and for-profit and non-for-profit world, and I believe what Deming always talked about, that everything is connected to everything else. And so from the quality perspective and the learning collaborative perspective, really the secret sauce is begin talking to each other and things evolve in a beautiful way. So welcome, we're excited that you're here. Thanks, Ann.
Thank you, Lynn. Next slide, please. So now I'll talk a little bit about housekeeping, how to use the chat feature. So on this webinar, we ask that you enter any questions or comments using chat. And in the graphic, you can see how to access chat if you aren't already familiar with it. And in the send or to drop-down list, select the recipient of the message. So what you'll do is you'll scroll all the way down and select everyone. Don't select all attendees, select everyone. And then just simply enter your message in chat and then press enter on your keyboard. And today we'd like you to please enter your role, your organization, and what is your organization's biggest concern about opioids today? We'd also like to be able to answer your questions in real time during the webinar. We will have time at the end of the webinar for a few questions, but we'd rather address your immediate questions and immediate concerns at the time when you have the inspiration for the question. So we close that loop for you. And then Lynn will be monitoring the chat, and so she'll interrupt us, or we'll have a little eye on chat, and we'll be able to include your question in the workflow of the webinar. All of the speakers too have agreed to share their email addresses. So if you have questions for them or Lynn or I or Jerry, we can answer after the webinar also. Let's see, the slides and the recording for the webinar will be shared after the webinar for all registrants. And we also may be able to include a link towards the end of the webinar to the slides. Thank you. And then next slide, please. So for the agenda, today we'll define the characteristics and benefits of a learning health system, or LHS. We will describe foundational POLIC activities to support LHS aimed at advancing evidence-driven pain and opioid management and improving patient outcomes. We'll have a roundtable with our distinguished guests on lessons learned from our POLIC participants, and guide participants in leveraging POLIC tools and resources for their pain and opioid and LHS efforts. Next slide, please. And now I will hand it off to Jerry for the next few slides. Thank you, Jerry.
Thanks, Ann, and greetings and welcome, everyone. So this webinar is about a learning community focused on pain and opioid management that grew out of an AHRQ-funded initiative to broadly advance learning health systems. LHSs are a key approach for realizing the healthcare quintuple aim, that is improving health and patient and care team experience while decreasing costs and achieving equity. So we wanted to start by defining what we mean by learning health systems using this diagram from that ARC work. The diagram illustrates how LHSs create a continually improving cycle from evidence about what works in healthcare to guidance and tools to implement that evidence, actions by patients and care teams, to data about the results of these actions, and back again to using the data to enhance the evidence base, and so on around the cycle. LHSs can be a care delivery organization, a country, or be defined at the global level. This virtuous cycle is fueled by people, including patients, leveraging technology to improve processes and learning. And when things go right, the result is achieving important goals, such as the quintuple aim. Next slide, please. As I mentioned, the POLIC activities and results we're talking about today are an outgrowth of the ARC Evidence-Based Care Transformation Support, or ACTS initiative that ARC funded from 2018 to 2021. ACTS engaged hundreds of stakeholders from diverse groups to develop a future vision, roadmap, and concept demonstrations for broadly fostering LHSs that achieve the quintuple aim. The ACTS roadmap called for identifying a few high priority clinical targets that care delivery organizations, patient partners, health IT vendors, and many other stakeholders would focus on together. The goal of this collaboration would be to connect interdependent efforts needed to accelerate progress toward that virtuous LHS cycle and the benefits it provides. Many ACTS participants started meeting weekly immediately after ARC funding for ACTS ended in late 2021. The goal was to continue stakeholder-driven efforts to execute the ACTS roadmap and realize the shared future vision that ACTS defined. Within a couple of weeks, the group selected pain and opioid management as the first target to focus on and launched the Pain and Opioid LHS Learning Community, or POLIC. Because there wasn't any external funding, the value proposition for engaging in POLIC centered on providing a mechanism for participants to get help achieving their goals through peer support, sharing, and collaboration. The secondary POLIC goal was to produce tools and strategies that could advance LHSs and care transformation beyond POLIC participants and ultimately to other targets. This approach to fostering collaborations that produce scalable benefits is a core of the approach outlined in the ACTS roadmap. Next slide, please. POLIC participants met almost every week between December 2021 and May of this year. There were typically around 15 people at each meeting. A core group of around 50 to 70 participants were significantly engaged in POLIC activities, and a mailing list of over 170 interested stakeholders received weekly updates on POLIC work. This slide shows a timeline of key things we did and produced in POLIC. We covered a lot of ground. For example, we created resources to help teams launch pain and opioid management quality improvement initiatives. We developed versions of the health service blueprint template from the ACTS initiative to help teams define and deliver a shared future vision for pain and opioid management workflows. We provided, under IPRO's leadership and funding, an ECHO educational series for patients and care teams on whole person care for chronic pain management. In partnership with Epic, we drove creation of new and powerful tools in that EHR's foundation system, including an opioid care gap report, a pain management navigator, and an opioid discharge report. Importantly, this Pollock work also helped lay foundations for approaching these types of tools and related workflows in a platform independent manner. For example, through explorations into documenting these workflows in standardized process modeling languages. Pollock also fostered other important steps to execute the ACTS roadmap. For example, it spun off another learning community initiative to accelerate care transformation for sickle cell disease. Pollock also drove formation of the overarching initiative and steering committee called for in ACTS to coordinate roadmap execution. This initiative formed within the last year is called Accelerating Care Transformation, or ACT. There's links on this slide and others in this deck where you can dive into the details of all these things I've mentioned. Since this past May, when the weekly Pollock meetings were suspended, we've been focused on identifying one or more partners we can work with in a Pollock phase 2. The goal is to build on the output and collaboration from Pollock so far to measurably decrease opioid overdoses in one or more geographic regions that include multiple health systems and different EHRs. We have a couple of leads for this that we're currently pursuing. The central Pollock goal in our last round of work was to help participants achieve their goals. So let's turn things back to Anne and our roundtable, where we'll dig much more deeply into these important details. Anne? Go ahead.
You're muted, Anne.
I'm talking away. I'll never learn about that button. Next slide, please. Okay, so now we will talk to our roundtable. We'll start this way, that just so that the audience understands that, we've been working with the folks in this group for many years. So we're going to be informal, and I'll be calling them out by their first names. And first we'll go through introductions that are brief, and then we'll turn back to the panel, and we'll ask some engaging questions to help you understand better how the panelists contributed to Pollock and integrated learning health systems into their work. So thank you, panelists, for sharing your experiences today. So I'm going to start with Rosie Bartel. And I'd like each of you, when I call your name, to introduce yourself, your organization and role if applicable, and why you engaged with Pollock. So Rosie, we'll start with you. Thank you.
Hi, I'm Rosie, and the organization I'm involved with is, one of the organizations is IHI, and I do a lot of work with them. And the reason I got involved with Pollock was because I live with pain every day, and but often, many times, I find that people treat pain and the symptoms of pain, but we don't treat the cause of the pain. And especially when I developed a healthcare acquired infection after a knee replacement, and they treated the pain of that many times, but not the cause of that pain, or couldn't treat the cause of the pain. And sometimes this is a form of misdiagnosis.
You really contributed to Pollock, and we'll dive back in different ways later on. Next is Dan Berlin.
Hi there. I think we solved all the technology problems. Sorry, it took a while to get on and visible. So I'm from the University of Michigan, and I work out of Department of Medicine and Anesthesia. And I'm a very cross-disciplinary person. I worked in pain and addiction and opioid pharmacology for about 25 years. And it was obvious that there was a big problem back in the 1990s. And so my goal in being involved with this was to, as the primary author of the original University of Michigan chronic pain guideline, was to sort of be a knowledge source for the clinical side of what was a very multidisciplinary group.
Stan,
Happy to be here.
thank you so much. Dave?
Everybody, my name is Dave Little. I am a physician who works for Epic. I'm a family physician by training. Practiced and taught family medicine in Ohio for 19 years before joining Epic in 2010. And it is a privilege to be part of this group so that Epic, as an EHR developer, can learn from the folks that use Epic on a daily basis, both from the patient perspective and the provider perspective. So it's great to be here.
Lisa?
Hi, everyone. My name is Lisa Anzizi. I'm a pharmacist and a manager at NYU Langone. I'm in the clinically integrated network, and my focus has been on med-related quality measures and medication utilization. And I've always been interested in improving care to patients with pain management, and also watching for opioid overutilization. So excited to continue working with IPRO because I've done a lot of work with them in the past. So this was just a continuation, and there was obviously a need for us in our organization based on pain assessment that we've done with them to kind of identify where there are opportunities to improve.
So much, Lisa. Next is Natalie.
Imagine this, the statuses for any clinical concepts like problems, medications, allergies, procedures, they're using different value sets. And sometimes the value is the same, but definition of the value is different. And these concepts can be shared using different HL7 standards. And you can imagine that interpretation varies, and understanding is so significant. The consistent understanding is very significant. And the issue is, if we are struggling to even understand whether the patient allergy is active or not. Or consider another situation where we have FHIR standards and we have very well described patient, but very concept of an individual. So we all know that the patients not become patients right away, and they may care before they become patient in some kind of health system. So these gap examples made me very deeply passionate, not only improving quality systems, but also quality of the data. And quality of the data, because data quality drives decision making, correct decision making, and optimized decision making. I'm really thrilled to be here. Thank you very much for inviting me today. My name is Natalie Agassi, and I'm a foreign trained physician and doctor of pharmacy with 15 years of experience in healthcare, advanced decision support systems, bleeding edge technology, looking 5 to 10 years ahead. Thank you.
Excellent, thank you. And what organization are you with, Natalie?
I'm with Oracle.
Excellent, thank you. And next is Jeannie.
Hey, hi, I'm Jeannie McKee-Kens. I'm full name's Eugenia. I am a MedTeach trained physician and associate CMIO for Duke Health. And as a part of that kind of work, I have worked really closely to try to improve the quality and safety of our opioid use within Epic. And I'm also somewhat of a data nerd, having done a master's degree in biomedical informatics at Vanderbilt. And so we have really tried to look at the data of to improve our overall kind of use and safety of opioids.
I'm hearing an echo from Jeannie. I'm wondering if our support, Sarah and Lynn, if you could follow up with Jeannie to help her with the echo, if possible. And then next is Christopher. Thank you, Jeannie.
Hi, my name is Chris Shanahan. I'm a general internist and I work out of Boston Medical Center and Boston University School of Medicine. I was interested in POLIC because I'm a practicing clinician and I treat both pain, chronic pain, as well as use disorders. And And I understand how EHR tools can, at the point of care, can make a huge difference. It's important to kind of know the context of the patient's care as well as, you know, the facts of the day. And the EHR is a critical tool to actually make that happen. I also have a background in clinical and research health informatics. So I feel like I was able to contribute a little bit by being able to speak both languages, both medicine and technology.
Thank you so much. And Janice.
Hi, I'm Janice Tuckey from Seattle, Washington. I'm a patient partner. And what brought me to POLC was I'm interested in the digital ecosystem to begin with. I'm very involved with evidence work from, from actually just from research to guidance to measurement to evaluation and all the way around as a patient. But I also have, experiential personal knowledge of opioid use and know of many people who have, not many people, but a number of people who have abused or overused opioids, as well as I've seen the benefits of treatment for that misuse and how it changed people's lives for the better. So that's what brought me here, and I appreciated the collaboration. Thank you.
Thank you, Janice. So I'm going to loop back around and we'll start digging into some questions. So I'm going to go back to Rosie, and I just want to say this, that Rosie and Janice are two patient advisors that worked with IPRO deeply in the last few years, helping us create patient-centered, patient visioned naloxone resources. We created a patient and family and care partner living toolkit to help patients understand where they can contribute their voice. They want their voices heard, and often they don't know how or where they can contribute in the broad spectrum of the ecosystem: hospital, primary care, research, advisory panels for different agencies. There's a host of areas where the patient voice can and should be heard. So, we're working on that. And I'm going to go back to Rosie, and I'm going to ask you, Rosie, what are some messages about opioids that you felt passionate about bringing to this group? I know you shared a little bit about your experience, and I know that you do your guiding light is storytelling with a purpose. So if you could share with us.
So when I came to Pollock, it was about sharing my story, but also sharing the story of other individuals, but especially about the fact that many times opioids are used and misused and given after surgeries and or with surgeries, and that not the wrong opioid is being used, or sometimes I would get prescriptions for 120 Percocets, and I'm like, I don't need 120 Percocets, but that's what they would give me because I was going home from surgery, and I would say, well, I don't really need that. And so one of the things I wanted to bring to this group was that to help physicians understand that patients really could be educated and taught how to use pain meds and pain and opioids and the appropriate opioids after surgery for the short term, and how to not overuse them. And because many patients are like, okay, you're going to give me 120 meds and you're going to tell me to take them every 4 to 6 hours. I'm going to do that until they're all gone. And we don't think about the fact that, that's going to probably lead to some opioid misuse. By the time I use 120 opioids, I might be down the road of misuse of opioids. And so I've learned a lot especially from Dan, about appropriate opioids and ones that may not make you be addicted to opioids or lead to opioid misuse. I found that not only could I help myself, but I could help others ask the right questions about opioid use.
So much, Rosie. And I think in some of our conversations during Pollock, we spoke of helping patients understand that what an opioid is,
Right.
that what they're receiving is an opioid. It's not always clear. And I think we also spoke about tapering, and patients often taper themselves off and to deleterious effects.
And the knowledge, the more knowledge you have about the medications you're taking, that's powerful. So, not only is the knowledge powerful for physicians, but it's also powerful for patients. I always say knowledge is power, and the more power a patient has and the more knowledge they have, the more powerful they will, and the more better decisions they'll make about their care and the use of the opioids.
Yeah, and that's what an LHS is. It's evidence-based to practice as quickly as possible. Any questions for Rosie? Any panelists? Did Rosie say anything that caught your ear that you want to ask a question about or probe? I'm not sure if Lynn or Jerry has anything for Rosie. It's Rosie.
I think, can I just say one thing? I think just another point, Rosie, to what you just said is also patients have better health outcomes when ready.
Definitely. Yes. Definitely.
So next is Dan. And I guess the question for you, Dan, did you accomplish the goals that you felt were important through Pollock? And I also want to note that Dr. Berlin was so instrumental to IPRO. He helped us create buprenorphine resources for OUD and also buprenorphine resources for chronic pain, and how to switch from pure mu agonist opioid to buprenorphine for pain, and worked on podcasts with us and the Echo series that Jerry mentioned earlier. So he was a great partner. And I want to emphasize that I'm going to be mentioning where we linked up and did IPRO work. It was all because of Pollock. It was all because we have a learning health system community that it happened, and that we all met and became greater than our parts. Dan, tell us more about Pollock impact for you and what you accomplished. Oh, you're on mute.
Can you hear me?
Yes.
So this is weird. All right, I just switched microphones. The other one is the one I've always used. I don't know what the problem is. Anyway, my goal was to try to proselytize the things that I've been pushing for some 25 years, some 15 years, but pain care is understanding psychology, and it's understanding people's social life. So now the biopsychosocial model has kind of caught on, but most practitioners still don't seem to know that much about it or have the time to deal with taking a social history. But you learn a lot about your patients. And so my goal was to try to teach people that opioids are not effective, that there are some effective things that we can do, whether physically or with non-opioid medications or psychologic measures. But what we can certainly do is deprescribe and not cause harm by the way medical care has gone now, which is ask 5 questions, make 3 diagnoses, and prescribe 5 drugs. And that's kind of the way everybody's treated and everything. I'm a primary care doc by trade, and I spend a lot of my life taking people off of meds. And so with opioids, it's a shock to people that perhaps 80% of patients improve dramatically just by simple taper of excessive doses of opioids. But over the last 15 years, we've worked very hard to try to, at the U of M, to try to bring buprenorphine into the mainstream if people dare to continue or to start opioids, full agonist opioids. And to this day, the vast majority of practitioners still do not know that it exists, even though there are 2 FDA-approved forms for pain. And so that became an important piece of this Pollock project, which was to try to inject some knowledge and IT pushes toward the uses of buprenorphine if people are going that way. So we got it into Pollock, but the grand vision of saying we'll change the world through Pollock, that we haven't quite gotten there yet. So that's where we are now.
Yeah, and IPRO, we're interested in promoting buprenorphine when applicable for chronic pain patients. Just as an aside, we have PharmD students that do their rotations at our site, and we have a student that is working on a document that identifies insurance barriers and what tiers buprenorphine is for pain with different insurers. So that'll be out soon. We'll have that available soon.
Well,
and I think that will be helpful for providers to understand, if somebody's got a certain insurance plan, what do they need? What do they need to be prepared for?
Well, I spent years on the inpatient and in the clinic services trying to convince people to ask the patients what insurance they have. Of course, now you can find it in the EMR usually pretty easily, but it still doesn't occur to people. And I see every day people prescribe things that their insurance won't pay for, and they just go unfilled. And to this day, the forms approved by Medicare, for pain, are generally not paid for by Medicaid and require a brutal prior authorization process for other insurances. And so if I write for transdermal buprenorphine, which is generic but expensive for somebody, a much safer drug than high dose oxycodone or something, I still receive back from Blue Cross, believe it or not, you should prescribe fentanyl. This is still happening. And I can't even make a connection to Blue Cross or Michigan Medicaid to talk to their pharmacy benefits people to change that.
So I think it's really important that we understand the barriers so that we could, try to move forward. So collecting data, understanding, and, adding to the evidence about that drug. One thing, Dan, that always struck me when you spoke was your inclusion of trauma-informed care. And that is also part of an LHS where you're looking at whole person care and responding appropriately. Do you have anything you want to add about how you identify and how you work with patients in a trauma-informed way?
Well, I can tell you as part of the psychosocial history, it takes 2 minutes. I've even posted videos on YouTube on how to do it to get out of people really shocking problems in their background. And the more centralized the pain, meaning it's not just a particular place, but if they fill out a body map of all the places where they have pain and they check off their whole body, think fibromyalgia and all those other centralized pains, the more likely it is that they have a trauma background. And certainly of those patients, probably 2/3 have significant psychiatric disorders, anxiety, depression, bipolar, that sort of thing.
And then addressing those concerns. Thank you so much.
The vast majority, and we see the same thing, in the GI clinic. People come in with nonspecific abdominal pain. They get $1 million workup. No diagnosis is made. They're called irritable bowel and they're prescribed several drugs, but nobody's ever taken a social history. That's a big problem.
Thanks, Dan. Is there any questions for Dan? Jerry, did you have anything to add?
Let's see if there's any questions, and then I just want to make a commentary on what we've heard so far. Let's see if there's any questions from the audience or other panelists before I comment.
Nothing in the chat right now.
So I just want to remark on the fact that I think what we're hearing now is you're hearing, a lot of different perspectives. And I think this is what was really exciting about Pollock. You're hearing about patients, people with lived experiences, challenges and needs and obstacles they're running into. You're hearing from subject matter experts that have, a lot of expertise about how you deal with just those sorts of problems. We've heard from health IT vendors, EHR vendors who are trying to provide a technology that help out with these various things we're hearing about care delivery organizations that are trying to, re-engineer care so that there's better processes and better outcomes. And that's really, I think, the kinds of things that you're hearing now. I just sort of wanted to weave them together and point out the fact that that's really what the essence of what Pollock was all about, to take all these different puzzle pieces, and everybody's sort of working in isolation in general, but we were trying to collect lots of different kind of puzzle pieces that are essential to get to the picture on the puzzle box, the ACTS future vision that we had designed, where learning health systems are achieving the quintuple aim very broadly for many different targets. So we took all this different expertise, all these different perspectives, and that's what lied behind, sort of, I gave a quick high level overview of the kinds of things that we produced earlier, and some of the later slides, there's some specific slides about that. So what we're hoping you'll get out of this presentation is to sort of see the kinds of things that we try to do with bringing together very diverse stakeholders to produce a broad array of resources that would actually be helpful to folks. And again, as we dig more deeply in the the next part of the panel into what the people did and what they produced, hopefully you'll hear more about the nuances that ideally will help in provide things to you that will be useful in your efforts to deal with these similar issues. And back to you, the panel.
Yeah. Evidence to practical application. That's what we're all looking for and here for in a rapid way, as quickly as we can in this rapidly evolving world. Dave Little, you're next. Thanks.
Yeah, thank you, Ann.
Yeah.
And
Did you
again,
accomplish your goals? Yeah.
I would say we certainly have. At the beginning of the webcast, Jerry showed a diagram of the learning health system cycle and how we go from generating knowledge to applying knowledge to analyzing outcomes, and from that generating new knowledge. The electronic health record really touches every phase of that learning health system cycle. So that is what has driven my passion for this topic and this group over time. Several years ago, Jerry came to me and said, we're interested in this LHS. Would you like to be a collaborator? And it was an immediate match made in heaven, for lack of a better term, because the EHR is a vehicle and a catalyst, and you use the term from evidence to practice. And the thing that stands in the gap between evidence and practice potentially is the electronic health record and the tools that can be used to mobilize that information and make it available to providers. Now, the electronic health record is not the driver of this process. The driver of this process is the end users who seek to apply these principles to their practice. And as an EHR developer at Epic, we are the students of our end users. And in end users, that includes providers. We've learned a lot from Dan and Jeannie and Chris as we've gone along, but also patients. It's been wonderful to have, Rosie and Janice as part of the discussion, as well as the quality assurance people, pharmacists. Lisa is here, Lynn and Ann, and it's great that it has been a great collaboration. And so we have learned a lot from a lot of people, and hopefully been able to contribute some things that are meaningful. They asked me to call out some of the things that we have contributed. We worked with Ann and Lynn directly early in 2023 to produce a pain management discharge report to summarize and convey information at the time of hospital discharge, so that a patient leaving the hospital and going to a follow-up provider would have a very concise summary of everything that happens that led them to this point in time, so that the follow-up provider could just pick up the ball and run with it and not have to start from scratch. I think Jerry mentioned a care gap report, which allows an individual provider to look at their whole panel of patients who are the patients that are requiring chronic opioid therapy, and are their individual care needs being met? And if those needs are unmet, then can we quickly identify patients with care needs and intervene on that basis? In the spring, we have a new tool coming out called the Pain Management Navigator, which will summarize all the clinical information that a provider needs to care for a patient on chronic opioid therapy in a single workflow, so that they can do that more quickly and efficiently. So it has been a privilege to get these ideas from the folks that use our software every day. Our goal is to be the catalyst that can help the learning health system move forward. From the standpoint of the electronic health record, I'm blessed to work for Epic. And so we've had a lot of good interactions with our folks. It's wonderful to have Oracle, as part of the team as well. And we'll hear from Natalie later. We want every provider, every electronic health record, every patient to have access to the tools and capabilities of the learning health system. So, yeah, it's been very exciting to me over the years to be part of this.
Thanks, Dave. I just want to say that when we worked with you on the pain management discharge report, it was a really rapid process. Dave and his team were excellent. I had several authors of the paper that were the SMEs working on it with us, and I thought it went really quickly. And that was, I think, a really good example of evidence to practical application in a rapid cycle plan. So that was really thrilling. Any questions for Dave? Any other questions? Any questions from the audience or the panelists?
There are a couple of folks in the audience that we're now working on another project with. So that's been another cool thing that
awesome.
Some folks came to us and are in the audience today. So
that's excellent.
Greetings all.
Oh, can I say something?
Yeah, definitely.
I think Dave is being very modest and about the contribution here, and it's a shame we couldn't get other EMR companies involved. The Care Gap report is very valuable for institutions to figure out what is going on in their own practices. It's easy to install it. It's not hard to run it. I'm afraid that a lot of places that use Epic, though, haven't utilized this valuable tool, and the navigator that's coming is going to also be very valuable, different from what Jeannie developed at Duke, but still the same idea. And these kinds of things prevent people from wasting time.
Yeah, we learned a lot from Jeannie as we put those ideas together. So
excellent. Thank you so much. Okay, we're going to move on to Lisa.
Hi, everyone.
Hello. Oh, Lisa, so could you describe some of the steps you took at NYU to develop a chronic pain dashboard and some of the lessons you learned and how you overcame challenges and et cetera, your experience?
And how that relates to all the Pollock stuff that Dave was talking about that was helped provide a wellspring for that.
Yeah, certainly. The first thing was to get leadership buy-in and support for, the staff that would help to develop it, getting them invited to these meetings with Pollock to help them understand with direct connections with, Dave and Epic super users. We certainly had our pain steering committee give input with what metrics we'd be collecting in the dashboard. I think that the lessons that we learned were that we needed to do some customizations with the metrics to make them better aligned for what we're trying to accomplish. And you sort of have to think about your workflows. The biggest challenge we had was with how the MME, the morphine milligram equivalents, were being calculated. And so early on, in order to get useful, meaningful data, we had to make sure that we removed the ability of providers to do free text directions. because that just didn't work then with the calculators. So we had to think about it, and before we turned on a lot of the reports, we audited them to see were they working properly, and then we work backwards to figure out, how are we going to capture that, the prescription drug monitoring program was in fact checked, and are we capturing all of the naloxones from only outpatient use? So we did a lot of work with that, and then fortunately, we put in place some system-wide changes that were tremendous to help us by having defaults, a 3-day default built into all of our short-acting opioids. That really helped us immensely, as well as we turned on what used to be called a best practice alert in Epic. It's now our practice alert. We set up opioid thresholds for acute pain and chronic pain and days supply. Putting all that in place really made for the dashboard to be more meaningful, because that really helped. And one thing that we saw, these rapid changes pretty quickly, that within a month of us putting those changes in, that we had a 44% decrease in the outpatient opioid prescriptions that were for longer than a 7-day supply. So really quickly, we saw that it was working. I'm hoping that this chronic pain dashboard is going to help me identify the patients who are the most vulnerable, that require further risk mitigation, so that we could target their providers as well as patients at a population health level. Because historically, we'd been doing it one plan at a time with lists, and it just wasn't very effective. We want to stay ahead of it, and I think that these dashboards are really going to help us. And, I'm pretty excited. I just found out today in talking with our work group that we were selected for Chime. I guess it's a technology magazine, to kind of share with them, the work that we're doing with this chronic pain dashboard.
That's excellent. We do have a question. Maria Michaels asks, is there a standard? There is a standard for calculating MME that is in the FHIR IG for CDC's opioid prescribing computable guideline. Was that leveraged so it could be scaled? Do you know, Lisa?
Yeah, we used it, but the problem is if you have free text directions that say 1 to 2 tablets, Q4 to 6 hours PRN, and there's no maximum daily dose, then you can't use the conversion factor because there's no maximum daily dose per day. So, basics like that you got to get right. And if they're not right, you got to figure out how do you make sure that every single prescription has discrete fields so that those conversion factors work.
Mm-hmm. Thanks, Lisa. Thank you so much for sharing. So we're going to move on to Natalie now. Natalie, how do you see AI contributing to the advancement of POLIC objectives?
I think the POLIC has a really great foundation, and I feel that AI methods can significantly enhance POLIC objectives, and we can integrate diverse clinical and non-clinical data and personalized care and recommendations to providers and to patients. And AI can unlock the semantic meaning of the healthcare data and streamline decision support and decision making, and optimize opioid and pain management. And I'd like to give you an example. I've been really inspired by POLIC and recently joined Dr. Jigar Patel team in Oracle, where we agreed to have opioids as one of the use cases for our new system.
Excellent. That's excellent to hear. Jerry, do you have any questions for Natalie, or anybody else have any questions for Natalie?
I just want to make a quick note. So again, the Pollock evolved in a very organic sort of way. There wasn't a funding source that here's a pile of money, go deliver these things. It was sort of very organic and stakeholder driven. So the specific settings that we focused on, the specific tools. So the question about ambulatory versus inpatient, there were different kinds of pain that we talked about. We talked about sickle cell for a while. So Dave, again, because of prior collaborations, Epic was a key player. Epic clients were key players initially, and Natalie joined relatively late in the process, but she's played a really critical role in these Pollock 2.0 explorations and collaboration with Dave and others. So in addition to the points you made about AI, Natalie, if you sort of want to say something about your thoughts about, this notion of having a Pollock 2.0 focus on multiple care delivery organizations, multiple EHRs in a particular setting, in a particular geographic region, I mean.
Right. We have discussed bringing not only the more data, but also bringing more stakeholders, such payers, to the table, right? And we want to see more of the engagement from different organizations that care and involved. And as I said in the beginning, that we not necessarily should think about individual as a patient. So we need to also consider socioeconomic statuses and add and probably look at the social determinants with a different lens and see how the social determinants can move the needle a little bit more. So standards and interoperability, and as I said before, standards are gappy, and it's important for us to understand and realize, and hopefully Pollock will move the needle in the standards directions as well, because we use standards for exchanging information, which is really important. And if we don't understand whether the medication is active or not, that's a problem. This information affects clinical judgment and and also affects the, as you know, the patient's outcomes.
Yeah, so much. So next we have
we're screaming toward the finish line. We'd love to hear before we get to the end of the road.
Yeah, Jeannie
Janison.
Am I better now?
It's still echoey, but I can still understand you. You might be in twice somehow.
I canceled a webinar's open. That happened.
Well, I'm afraid if I cancel this one, go out.
Do you turn your speakers down? Do you have speakers on?
I guess I turn my speakers down. Does that make it better?
No.
Well, we can understand you.
Yeah, let's try. Let's go ahead.
So
my question to you is, what do you think is needed to advance the broader environment and role that Pollock played, and how could we move this forward? And anything you could tell us about visit navigators? You were very instrumental.
I really thought that there was a benefit. One of the first few things I did after I joined Pollock was kind of participate in doing an inventory and pulling kind of everybody's tools about how they used opioids and guided things. That was incredibly helpful for me to understand the lay of the land and how other organizations. I strongly believe the more that we can standardize, especially opioid care across health institutions, that we will improve our overall processes about how we take care of patients. I think a good example of that is, the idea of setting limits of like the number of opioids. We do 5 days, other people do 3 days, but setting that really is something that should be a standard of clinical care. And I believe that EHRs that we have are really potentially really good springboards for kind of building that in. And I know Epic has done that. I think that there's some interest on the Oracle side. I'm sure the other EHRs are too. So I really feel like the benefit of Pollock was kind of in helping to start that process of standardizing and kind of defining what a standardized care would be. We have set up navigators. I am completely happy to kind of go with Epic Space functionality, and we will try to move there, because when we build things, there's a lot of work on our side to do that, but then, it's kind of ongoing work to keep everything up. And I think another thing that has been really beneficial for me from a Pollock perspective, besides that inventory portion initially, was to say, okay, what other things are we missing here? A good example would be like kind of fentanyl testing at the point of care in EDs and those types of situations. That was not something we had initially, but it was something that I became aware of and that Duke has just recently absolutely turned on as well, which I thought was just really important, but that's also something that you learn from kind of just standard of care of what other people are doing. And it's been a real pleasure working with Jerry and Dan and Dave and everybody here and kind of really having an opportunity to kind of improve our care of patients by learning from others.
So much, Jeannie. You know, focus on standardized care is a goal for quality improvement too. And next is Christopher Shanahan.
Hi. So the question is, what did BMC get out of Pollock?
Out of Pollock, yes. I'm sorry. Yes. What are some of your takeaways from being a part of Pollock?
So what I learned is that if your institution isn't ready, then your ability to kind of implement or even to suggest change is limited. And the experience at BMC was kind of unusual. It's not like people were not interested in the topic. It's that the BMC as an institution was kind of unable to collaborate with outside entities for a variety of reasons, many of which I don't understand. But sometimes at least what I learned at BMC is that some institutions are just so wrapped up in keeping the lights on that they just can't expand past. And even though these things are mandates and there's a lot of nodding and waving and saying it's important, it's hard to kind of garner the resources to make things happen. And so we had a lot of false starts. So I think the takeaway is if your institution isn't on board, you're not going anywhere.
Right. And we have discussions on, you know, some effective ways that you can make the business case for C-suite. We did create a slide set around that in Pollock to try to help leverage that. You know, this is not a new story, Chris, that we've heard. So thanks for sharing.
And the care gap report will help a lot with that. One of the reasons why we developed the care gap report was to help motivate the C-suites, and that's becoming available now. Janice?
We only have 3 minutes left. We went a little bit over on the panel, but I think it's really important that we heard from people in the real world and the situations. And I wanted to make sure that Janice had a chance to contribute about what messages about opioids do you have that you're passionate about that you'd like to share?
So I just want to say years ago, I actually lost a friend to heroin many years ago. So I realized that opioids were an issue. And then I lived in a house with other people. And one of the gals there had been misusing opioids and went on buprenorphine, and it totally changed her life. And she was also with CBT. I mean, she was using other therapies along with the buprenorphine, where she was able to regain her family back, get the children's, and now she has a house. They bought a house and is very, has a happy family. So seeing that firsthand, I was like, wow. And I'd never heard of buprenorphine before then. But as an engaged or activated patient, I came to Pollock because I myself started searching. I recognized, where is the cycle in this? How does the research that I'm involved with end up into the guidelines I was involved with, or the measurement, where I recognized it as being a cycle, a continuous cycle? And so searching it on the web is how I actually reached out to Jerry. I found it through our act transformation and became involved. So recognizing how important it is to have the different voices at the table to move forward things like the care gap reporter. I believe that the patient voice was central in Pollock and really integrated into some of the products that came out of it, bringing up information that could be used. So I just feel it's very important to be, purposeful patient engagement and I appreciated Natalie mentioning that that's a step she'd like to take next. So it is to have that voice or care partner in there. Thank you.
Thank you so
Thanks
much,
for
Janice. So we have 1 minute 1
So we're
minute,
screaming
Danny.
to the finish line. So I'll just give you an overview of what's on the next couple slides. So I think that everything that we're trying to convey is really summarized by this African proverb. If you want to go fast, go alone. If you want to go far, go together. And that's really what Pollock was all about. And if you flip to the next couple slides, just so that you know what's in there, there's links to a lot of the specific tools that we were mentioning earlier. You can go to the next slide. I mentioned service blueprints were an important part of what we did. So again, you can reach out to us if you want more information about this. And then the next slide as well. And then there's some links. This has some more Pollock specific links. There's also links to the stuff that we did in ACTS, the ARC funded work that was a springboard for Pollock, more links about getting information about Pollock, and then information about the Accelerating Care Transformation initiative that, as I said before, is a key part of what was recommended in the ACTS roadmap. So we really appreciate all of your time and attention. Last slide, and then Lynn, Ann, I'll let you close this out.
Sure. Next slide. If you want to grab our email addresses, I also put mine in the chat. And if you have any questions after this webinar, please reach out. We'll be sending the recording and the slides. And also the slides are in a link in chat. So I think we're set. Thank you so much for joining, and thank you panelists for this great discussion and for participating with us. Bye all.
Thanks everybody.
It just looks like us duckies in the room now. Do we have any kind of recap? I mean, we didn't get to go through your final slides, Jerry, but I think you did a great job going quickly. They know the resources are there. I think that's pretty great. Thank you all. I thought it went great. What do you guys all think?
I agree.
A lot of panelists, but I think it was important that all your voices were heard.